All right. Thank you, Dr. Pat. I'm going to just assume that everybody can see my slides.
You are good to go, sir.
All right. So I'll be talking about nerve transfers in tetraplegia. For those of you who don't know, I'm one of the fourth-year residents here. So here's the outline of the talk for today. So just going to start here. She does have
Raise your arms up to the side and bend your elbows as much as you
able
can.
to abduct her shoulders. She has functional contractions at the elbow.
Now try to straighten your arms.
Can't.
But she's unable to extend her elbows. She also has no real hand function at all. So she came to us 6 months after her injury, and she had the goals of being able to feed herself, push herself up in her wheelchair, and to maneuver her motorized wheelchair. So we talk about the options for her, but first let's talk about spinal cord injury. So over half of spinal cord injuries happen in the cervical trunk, leaving patients with tetraplegia, so upper and lower extremity motor dysfunction. It affects 40 to 100 million people, and it affects about 12,000 people per year. And these are mostly people that are young and previously healthy with rare complete recovery. So as you can imagine, this has a pretty big economic cost for them. So it costs about $800,000 in their first year, and then another $100,000 for each subsequent year, making the lifetime cost pretty high, as you can see, for somebody who was previously young and healthy. Also impacts their ability to complete any of their ADLs depending on their level of spinal cord injury. So to talk about the pathophysiology around the injury and defining the injury, you have your supralesional segment, so that's everything above the injury here, where you have volitional control of all your muscles and no real injury. Then you have your injured metamere here in gray, so that's the zone of injury, and it could be pretty small and just affect one level, or be pretty large and affect multiple levels. And since the anterior horn cells are here, you're going to get a lower motor neuron injury at this level. So that actually leads to Wallerian degeneration, and you're going to get motor end plate degeneration of the muscles. So any type of injury here, if you want to do some type of nerve transfer, it's going to be time sensitive. And finally, you have your infralesional segment, so everything below your zone of injury. You don't have any volitional control of these muscles, but the lower motor neurons and your reflex arc are intact. So you're actually not going to have as much motor end plate degeneration. So any type of transfers to that level probably aren't going to be as time sensitive. So when we look at function by neurological level of injury, kind of differs in terms of independence. So you look at patients with their highest cervical cord injuries, so C4 or higher, they have no discernible upper extremity function, and they're completely dependent upon others for their ADLs. C5, C6, these patients will have some shoulder function, maybe some elbow function, but really they can't extend at the elbow or have any hand function like our patient. So they're still going to have difficulty living independently and completing any ADLs. C7 level is where you kind of have the point of independence. So these patients, when they can extend at the elbow and basically move and transfer, they are the highest level where they can generally live independently. So as you can see, a small improvement in function for patients with tetraplegia can lead to a pretty large increase in their independence. And some reports show that 80% of patients after upper extremity surgery for their tetraplegia are able to accomplish new ADLs. So with that said, we know that about 75% or more of patients with tetraplegia would benefit from tendon transfers, but in fact, only 14% of eligible candidates actually get these procedures. The reason being, we think it's because lack of communication between the different teams that are collaborating on their care, and also there's a lack of surgeon comfort with the procedures that oftentimes they know their patients need to get better function. And just to add to it, when you survey patients with tetraplegia, upper extremity function is the most desired function by far over bowel and bladder function as well as sexual function. So we talk about the management of tetraplegia. We already defined the levels of spinal cord injury. There are other ways to classify it. I think everybody here has seen the Asia classification, but that's not really detailed enough to help us guide treatment. So the International Classification for Surgery of the Hand in Tetraplegia, or referred to as the ICS classification, is a little bit better in that it just defines which muscles are functioning at a grade of 4 or higher, again with grade 4 being active motor against gravity and resistance. And it tells you which muscles are available for tendon transfer donors. So here's kind of everything, your ASIA, spinal cord injury level, and ICS classification all on one chart. And our patient, she was somewhere in the C6 level, group 2 or group 3. She has ECRL and ECRB. And when you get even more detailed, that'll tell you what muscles are in fact intact above her level of injury and what things do we need to try and get back below the level of injury. So historically, we would do this with tendon transfers, which means you take the tendons from redundant muscles and you transfer them to paralyzed muscles. There are a couple benefits of these or advantages. They give you pretty good strength. They're reliable. We've been doing them for a long time. You get function immediately after the tendon heals, and there are no timing restrictions. Typically, these are done over a year after the spinal cord injury. However, there are some disadvantages. It requires extended immobilization for the tendon to heal. And if you have a patient who's just teetering on the edge of independence, then being immobilized for 3 to 4 weeks is going to put them back a level and make them dependent during that time. Also, you only get one tendon, one function, meaning you take a tendon and it only allows one motor function. You can't get multiple functions out of one transfer. And then when the patients have an injury at the C5 level or higher, we don't really have any good options for tendon transfers. Also, these tendons and muscles are not doing their normal function, so they can weaken and stretch over time, and you do lose a little bit of strength with your transfer. However, this is how we did things historically. So if we had our patient, we would try to think up a plan that includes tendon transfers, osteotomies, and different arthrodecies and tenodecies to accomplish her goals. For her, that would mean correcting her supination contracture, which we use in osteotomy, getting her active elbow extension, and then trying to get some active hand function to get her some key pinch and grasp function. So you look back at our patient, C6 level was her motor injury, ICS classification, group 2 or group 3. So we have brachioradialis and some wrist extensors for tendon transfers. And in terms of how we can correct her, we can do a pronation osteotomy to correct her supination contracture. We can do a tendon transfer, take her deltoid and transfer to her triceps to get some elbow extension. We don't really have much for hand release, but we can do a brachioradialis transfer to a thumb flexor and some other funky hand things to try to get her a key pinch. But we're really here to talk about nerve transfers. So what that means is you take the nerve from a functioning muscle and you transfer it to the nerve for a non-functioning muscle. This allows for volitional control of that muscle. And there's some keys to actually doing a successful nerve transfer. You want to make sure that where you're doing your coaptation or your transfer is as close to your motor target as possible. We all know that nerves grow at a certain rate, so that whole 1 inch per month that we talk about. So the closer you are to your target, the better. Also, we want to make sure that we do pure motor donor nerves to pure motor targets. We'll talk about that a little bit later. And you want to make sure you have enough axons directed towards the target. So this is one of the reasons why you don't hear about many lower extremity nerve transfers, because you need a lot of axons to fire the muscles for ambulation, and you just don't have enough to transfer to those muscles. And you want to make sure you have negligible donor morbidity. So again, the benefits of nerve transfers, or the advantages, you can innervate multiple muscles from a single donor nerve. So one nerve can do multiple muscles, which is great. There's no prolonged immobilization. The muscles are doing what they're supposed to do or what they were made to do. And you have minimal donor site and muscle morbidity. Also, for your high cervical injuries, you have more options, or any options, including the spinal accessory nerve and your axillary nerve. But there are some disadvantages. There's a long delay to see your functional outcome. You've got to undergo Wallerian degeneration and nerve growth, and as we know, that takes a long time. If your transfer is 10 centimeters from your target muscle site, then it's going to take over 10 months to actually see that functional outcome. And in terms of reliability, we'll take a look at the results, the outcomes, but it's mixed results, and it may be technique or patient dependent. So we talk about timing to nerve transfers in tetraplegia. This is something that is debated a little bit right now. Typically, you want to wait until patients have full spontaneous muscle recovery before doing any upper extremity surgery. With tendon transfers, historically, that meant we'd wait over a year until after the surgery. However, there is some evidence to show that if you have no motor function at 1 month, then you're pretty unlikely to recover any real meaningful motor function at 1 year. So maybe we don't have to wait as long. And in reality, now, generally people will go and do the nerve transfers between 6 and 12 months after injury. Again, you know, at the injured metamer, you're going to get that motor end plate degeneration at greater than a year. So it is a little bit time dependent, but less so for the infralesional segment. So we look back to our patient, and now if we think about what are her options if we include nerve transfers, to correct her supination contracture, we're still going to do the same thing, the pronation osteotomy. For elbow extension, we could do a posterior deltoid to triceps tendon transfer, or we could do an axillary nerve transfer using the branch teres minor and take that to the long head of her triceps. And that doesn't burn a bridge to do a tendon transfer. For hand release, we can take the nerve that goes to her supinator and transfer that to her PIN to give her some finger and thumb extension. And then for key pinch and finger flexion, we can take the nerve going to her brachialis or musculocutaneous nerve and transfer that to her anterior interosseous nerve. And all these transfers still leave us with tendon transfer options. So let's look at the outcomes of nerve transfers in tetraplegia. So this is just a list of all the different studies over the past 40 years or so. And if you look at the number of patients, you can see it's nothing but case reports and small cohort series. And there are huge differences in the techniques used, the concomitant procedures, the injury levels, the completeness of injuries, and how they measure the outcomes, including just how they measure strength. So it's a little bit of a mess. When we look at the early reports, they transferred the musculocutaneous nerve to the entire median nerve. And this is transferring the nerve to a mixed motor sensory nerve, which is kind of breaking the rules, and they only had pretty fair outcomes. And this is breaking the rules because if you transfer a nerve like, say, your musculocutaneous nerve to a mixed motor sensory nerve like your median nerve, bear with me, these red things are supposed to be axons. Those axons are going to go to both your motor targets and your sensory targets. But these axons going to sensory targets would be better served going to motor targets to give you more strength. So now we think you should just transfer to a pure motor nerve, like say your anterior interosseous nerve. And then when your axons grow, they only have motor target options to go to, which may improve function. And I think we're starting to see that in the literature. So you look at the results of transfers for elbow extension. The donor is usually going to be branches of your axillary nerve. You can use the entire posterior branch of the axillary nerve, or you can just use the nerve teres minor, as you can see here. Bertelli is a Brazilian surgeon who's done most of the research into nerve transfers for tetraplegia. And when they took the posterior division of the axillary nerve and transferred it to the triceps, they actually had all patients have at least anti-gravity strength, with 85% being 4 out of 5 strength. In their case report where they used the teres minor branch, again, all patients had at least 4 out of 5 strength. So pretty decent outcomes there, but with small numbers. We look at trying to reconstruct key grips, so thumb and finger flexion. Historically, you can use the brachialis branch and the musculocutaneous nerve, like we said before, transfer that to your anterior interosseous nerve here, or specific motor branches. There are 8 case reports out there that show all but one patient have at least anti-gravity finger and thumb flexion. So something that looks like this, which is probably pretty great, right? I would take that. However, when you look at some of the larger case series, again, coming from Bertelli, he used multiple different donors. And when he used the musculocutaneous nerve, he actually found that he had no recovery in half of his patients. And reason being, it might be that your musculocutaneous nerve transfer happens here in the mid-humerus. And then those axons have to grow and go all the way down to the elbow to hit their motor end targets. So that might be a reason why their recovery has been poor. Same issue with the brachial radialis. Over 70 or 75% of patients had no recovery. But then when you look at transferring the nerve to ECRB to the AIN, he actually had all patients have at least 4 out of 5 strength. That might be because ECRB nerve transfer happens much closer to the elbow where all those motor end targets are. So probably have better outcomes with shorter distances to travel for those axons and more targeted transfers. Then finally, when we're talking about thumb and finger extension, typically you'll use the nerve to supinator and transfer that to your posterior interosseous nerve. Bertelli, again, 7 months after injury, did this transfer, and 90% of patients had at least anti-gravity thumb and finger extension. However, he also did the transfer in a group of 5 patients 4 to 6 years out from injury. And they're a little bit less, so only 60% were anti-gravity in terms of thumb and finger extension. However, this still showed that there is a chance to get some type of function with a long delay. So when we talk about what we actually do, Totolo proposed an algorithm that combines both tendon and nerve transfers, and this is probably what the future holds. So he basically proposed nerve transfers for function that don't burn bridges with your historical tendon transfers. And that is what our patient actually got. And a report in the Lancet last year actually did this. Prospective series, 59 nerve transfers in 12 limbs that were accompanied by tendon transfers as well. Patients with C5 spinal cord injuries or lower, and on average, it was done 11 months after their injury. They had 100% of patients improve on various validated measures of ADLs. They had their highest satisfaction in the supinator to a PIN nerve transfer. And when you look at their motor outcomes here, you can see in the triceps, it was at least anti-gravity in most, but then 4 out of 5 is their median for everything else. So pretty good overall in terms of outcomes. So just to summarize, the current literature seems like combinations of nerve transfers and tendon transfers are best to maximize functional outcomes. When it comes to nerve transfers, we're seeing pretty good results with elbow, finger, and thumb extension, but we're seeing mixed results with wrist and finger flexion. Possible reasons for this may be the shorter distance to the target and the longer follow-up time in those studies. Also, we know that targeted transfers look like they're probably going to do better, and the time to transfer as well as the age of the patient may matter. So if we go back to our patient, again, 9 months out from the MVC, unable to extend at the elbows or have any hand function. So she basically received a combination of nerve and tendon transfers. Here were her goals: feed herself, push herself up, control her wheelchair, and she got all of the nerve transfers we talked about, as well as some tendon transfers, including a posterior deltoid to triceps tendon transfer. So 1 year postoperatively, you can see she maintains all of her shoulder function that she had beforehand. She has active elbow extension, which she did not before.
Hand to your mouth.
And she doesn't appear to have suffered any weakness as a result
inside.
of
Great. And then let's see. Keep your elbow at your side and turn up.
So also able to supinate and pronate. Remember, she did have the contraction before.
Excellent. Okay, let's see. Raise the right arm.
And then we look on the other side again.
And let's
just the right arm.
Yeah.
No weakness as a result of the nerve transfers. She has active elbow extension.
And back again.
Anti-gravity.
Good. Perfect.
And then in terms of her goal of being able to feed herself, it seems like it's a pretty small thing, but we weren't able to do this beforehand, and she is able to do it after. So in terms of future directions, we need more data. We need to figure out more donors for the patients with high cervical injuries. We need to standardize our outcome reporting. We need to figure out ways to preserve those distal targets. We need to have larger trials. We need to improve our patient selection. Also, there's a growing body of literature that our neurosurgical colleagues are getting into with neural implants and functional electrical systems. And there's probably some use for nerve transfers with myoelectric prosthetics and robotic limbs to help patients with tetraplegia as well. Just a plug for our brachial plexus and spinal cord injury clinic. If you do have these patients, please refer them over. You can consult the hand team if you're at Maine. And I just want to thank Drs. Gaston, Loeffler, and Reed for their help with the presentation. Here are my references, and we'll take some questions.
That's great, Randy. Thank you. That's awesome work that the hand and brachial plexus team is doing there. I have 2 questions to start us off. One, will directly for you, and then one maybe you can enlist some of the hand team to answer the question. So first question is, we saw that TMR showed up a year or two ago for the first time on the in-service exam for orthopedics as an emerging technique for neuroma prevention. As this is becoming more popular, if you had to guess what should the residents know as the most important answer to a question for tetraplegia transfers? Is there sort of one that everybody should sort of have in the back of their brain and expect to see show up on that test? And the second question is, as far as building this program and continuing to recruit patients, is there any upper cervical spine injury that the hand and brachial plexus team doesn't want to see? I mean, should this be an automatic referral for all of our spinal cord injury patients who have upper C-spine injuries?
In regards to your first question, I don't know if we have data to say that there's anything on the in-training exam in terms of a specific nerve transfer or tendon transfer that would show up. I don't know. I think that there's more data coming out, especially in the past year, that would say if you do have a patient with tetraplegia, then that shows up on the in-training, then referring to whether it's neurosurgery or hand surgery for combination of nerve and tendon transfers would probably be the answer. But I don't know if I can speak to it more than that. In regards to the second question, I'll end up deferring to the hand team, but I think it's generally if you have a peripheral nerve injury, a spinal cord injury with upper extremity weakness, they generally will see anybody at least once in the brachial plexus clinic to evaluate and see if they're appropriate.
Yes, Glenn, I'll take on both of them. If I had to guess, I don't think it's quite there in terms of an in-service question, but if it was, I think the two most likely would be, number one, just the recognition that the zone of injury undergoes standard wall area degeneration, as he said, and that the infralesional muscle groups do not. So they still have viable motor end plates even years later, which is not something that got taught classically. I think if I had to guess, just understanding that concept would be probably the first thing an in-service or boards would probably ask before they got to specific transfers, because there's too much variability in the results. So just understanding that. In terms of who would we see? Yeah, we would absolutely see everybody. I agree with Randy. And I think it's great to at least meet with them and give them the option. I think it would be a really neat QI project to get to where those patients seen in Maine just get a consult for the hand team. We're happy to come see them in the hospital. And then if we feel like there's nothing we have to offer from a reconstructive standpoint, we can just provide them education. If we feel as though there is, then we can follow them for that. Certainly the more timely referrals, even the ones that had the transfers years later, as you saw, didn't do as good as the ones acutely. So being able to get to them early makes a big difference in their outcome.
Okay. Any other questions from the audience?
Hey, one question. Previously, we had the trauma path team, and I know they were very aware of these transfers and trying to get people plugged in earlier. Since that's gone away, have you guys seen a delay in these patients getting presented to your clinic? That went away about a year or 18 months ago.
Good question. I don't know if it's a delay or just a full-on drop-off. We've had both. So yes, we've seen a lot of patients late, but we're still happy to see them because even late, there's still tendon transfer options. I mean, I think one of the most important slides he showed is early on that 80% of these patients would benefit from a functional standpoint to have something done. It doesn't mean 80% need it or emotionally are able to go through more surgery. Some of them, it's been a long road to get to where they are, but at least being able to talk to them about what their options are. Historically, honestly, just the referrals are low for this, which is disappointing that the patients aren't offered it. I don't think it's a matter of they're being offered and they're declining it. I think it's just not on people's radar to think to send them to hand. It's just more of they get their spine fused, send them to rehab, and then PM&R sees them. They do a great job with them over there at the rehab center. But and then more and more, it's coming back on their radar. But I think historically, it's just not on their radar. Rehab them and good luck in the future.
It would make sense since Dr. Parrish spoke up, and I see Dom about to talk. Maybe he's going to answer this. This might be a good QA project for one of the neurosurgery residents to see if we could develop a pathway where this is a default and an expectation for our spinal cord injury patients through CNSA. Dom?
Yeah, that was kind of what I was going to talk about. I was going to see if Glenn was okay with the concept of coming up with a pathway that the brachial plexus hand team gets an automatic consult for, cervical spinal cord injury patients.
Yeah, I think it'd be outstanding, Dom. I really do.
Well, we'll take it offline, but we'll circle back, Glenn, and I'll come back to the residents. That was a great talk, and I think this is an underutilized resource that we have for our spinal cord injury patients.
I would